Two.
Once again, that got it is there. How do I remove that got it? Okay, yeah, fine. Yeah, go now. Yeah.
Sir, we are live now.
Okay. Good evening, dear doctors and friends. I welcome you all to my center SSOC's 6th Meet the Masters course. SSOC stands for Sarthi Superspecialty Orthopedic Center from Gavipuram, Bangalore, India. Today's faculty are Dr. Harun Gupta from United Kingdom, Mr. Edward Smith, my hip mentor from UK, Advocate Ananya Joshi from Mumbai, and myself, Dr. Srikanth KN, Proprietor and MD of Sarthi Superspecialty Orthopedic Center, Bangalore, India. And we are this kind of hybrid meeting. We've got my close friends here in Hotel Chancery Pavilion. So the program for today is at the outset. I would like to thank all the faculties who have spared their valuable time today to educate us. Special thanks to Dr. Ashok Shyam, Dr. Neeraj Bijlani, and Maharishi from OrthoTV for this live broadcast, which is going throughout India. I thank to all the sponsors who stands shoulder to shoulder with my center in these difficult times, particularly Rajana from Sipla. And I thank all the delegates who have spared their valuable time, both online and offline, for this unique thought-provoking CME stroke webinar. This is a hybrid meeting because part physical and part going live to India via OrthoTV. This is the program details for today, and I think we start off with the registration welcome. And there's a short video, 20-25 minutes on what's new in orthoplasty, focusing mainly on robotic surgery. So I'm just going to play that. And then after that, the official program will start around 7:05, 7:10, where we'll welcome and introduce the faculties and the guests of honor who are coming today. And then the first talk will be from myself. I'm going to be talking about artificial intelligence in healthcare and orthopedics. Is it a boon or a bane? And that will be followed by a brief question and answer sessions. Then I'll be talking about, I'm a Southeast Asia coordinator for the world famous Bristol Hip Orthoplasty course. So I'm going to be talking about the BHSE 2023, which we are bringing live from Bristol end of November, that is 30th of November and 1st of December. There's a welcome. My mentor, Edward J. Smith, was supposed to join online live from Bristol, but he had some other appointments, so he sent a lovely video welcoming all of you. And that'll be followed by a 5 minutes video on what exactly we are discussing this year, pushing the boundary of understanding in orthopedics further, as far as hip surgery is concerned. Then, as usual, since COVID time, we started this creativity corner, and this is to understand what exactly is happening with human beings, to try to make sense of a post-COVID world, and also see where the human conflict comes and how we can resolve the human conflict. So you have to see that it's a very popular section. We'll deal with that. After that, we have the guest lecture. We have introduction to our faculty from UK, Dr. Harun Gupta, who is a consultant radiologist from Leeds. And he'll be enlightening us about the role of artificial intelligence in radiology and, training of the future radiologists. And I think, he's got a unique kind of talent where he's got a newer concept to train the radiologist throughout the world. And that he'll be discussing and sharing with us for the benefit of the viewers. And that'll be followed by a question and answers session. And then I will introduce, our advocate, Ananya Joshi from Mumbai. And she'll be talking about the most fascinating topic. And I think, as they say, saving the best for the last. And this is called as regulating the regulators in India, what every doctor or citizen should know. This is a very fascinating subject, and it's very, very topical as well. And so let's hear from her. And I thank her for coming and joining all the way from Mumbai. That'll be followed by a brief question answers, and then there'll be felicitation of the faculty and the guests of honor, and that'll be followed by questions and then a vote of thanks and close. So I think before I go into introduction, I would like to play this video, share what's new, particularly robotics, what's happening really. So I'll just stop share and go to this video and start it. artificial intelligence is very closely linked to robotics. If you look at AI and orthopedics, a lot of people only talk about robotics, although they are completely two different things. This talk is predominantly about robotics, how robotics has revolutionized at least orthopedics. So, let us see how we link. But, I'll explain in detail that robotics is not artificial intelligence. They're two completely different concepts. Just bear with me, trying to open the keynote.
Sir, what about, is there any problem?
Yeah, I'm not able to open the keynote. So any suggestions on how to open the keynote?
No.
Yeah, so because the robotics in orthoplasty is in keynote. Yeah, I think it's open now. So just let me play that and then I'll screen share.
Dear doctors and friends, I welcome you all to this presentation.
Can you see the slide now?
Yes, sir.
Dear doctors and friends, I welcome you all to this presentation on robotics in orthoplasty. Is it better in 2022? The real answer. Many of you know me. For those who do not know, this slide is there. But I'd like to thank the organizers for this opportunity and welcome all the delegates to this, what I call as a futuristic talk. I'm also director of the International Meet the Masters course. We are running the 5th course this year. We do it every November, and last November, we sort of push the boundaries in orthoplasty as we do normally by talking about robotics in hip and knee orthoplasty. And this is a 4-hour program. I'm trying to condense this program into 8 minutes. I'll try my best. As Sir Isaac Newton said, made an iconic statement after discovery of gravity: if I have seen further than others, it's by standing upon the shoulders of the giants. My gratefulness and gratitude to my teachers, both overseas and in India and Bangalore, and many of them are here in this hall. The big ones are Professor Alistair Hart, nicknamed the Hospital Detective by the BBC, standing on my right-hand side, and Professor John Skinner, President of British Orthopaedic Association. Very grateful to Dr. Jonathan Keenan, who a decade ago taught me about computers and robotics in orthoplasty. My love and passion for CAS and robotics started here with Dr. Jonathan Keenan in Plymouth. Grateful to my hip mentor, Dr. Everett Smith. Many of you know him. This is Everett doing the first spare approach with me in India, in All India Institute of Medical Science, New Delhi. And on the right-hand side, Everett is here in Lee Meridian in Bangalore, in the first Meet the Masters course with my professors, Professor J.K. Reddy and Professor Purushottam. I worked with the past president of British Knee Society, Dr. Richard Parkinson. He is my mentor for knees, and he inspired me in knee surgery way back in 2002. That's 2 decades ago. Coming to today's topic, we know 20 million people suffer from knee and hip OA in India, and 1/4 of them need some kind of intervention at some point in their life. COVID proved there's big doctor shortage in India, and because of this, there's a big skill shortage, and every trained and untrained surgeon is forced to do knee and hip replacement and revisions in this scenario. A basic tenet in CAS and robotics is if I feed garbage into the robot, it gives me garbage out. And the basic tenet in orthoplasty is that if I fail to prepare for surgery, I prepare to fail during surgery. Knee, we know it's a complex three-dimensional hinge because it opens like a door hinge, but also rotates at the same time. We know the types of knee replacement, partial knee replacement and osteotomy is coming back in a big way. Hence, my center bought the basics of knee osteotomy course in December last year. It's available. The link is there in the last slide here. What's new in TKR, the robotics? It addresses alignment versus balance conundrum in 2022, provides predictable accuracy, makes surgery safe and recordable, and prepares better surgeons for tomorrow. It acts like a patient-specific implant because we now know that all knees are not the same. What are the common myths I faced when I moved to India? Eyeballing is better than computer navigation robotics. With 1 millimeter accuracy of the robotics, this debate is largely settled. One size fits all. We know the truth is that every knee is unique, as I will show you. Looking at X-ray and doing a TKR 2022 means giving a two-dimensional solution to a problem which is essentially a three-dimensional. You can always plan for surgery on the table. It's never the truth. Anyone can do TKR, THR in India. This is what I call as a EBTA-driven concept of hospital owners and CEOs of big corporates. And it's a myth because if you listen to Dr. John Insall, father of knee replacement surgery, he breaks this myth quite nicely. He said that knee replacement is a soft tissue operation with some bony cuts. So it's taken 50 years for us to understand what he really meant. Respecting the soft tissue envelope, aim for functional alignment, because the balanced trims alignment is the latest teaching in 2022. In 2022, there is no role for crucial MCL release. In 2022, we are debating mechanical versus kinematic alignment, adjusted mechanical versus inverse kinematic versus functional alignment, and proponents for each of them. Why TKR as soft tissue surgery? The role of ligaments in the knee is unique. Each ligament is doing multiple functions, and some of the ligament function is still not understood in 2022. We know knee has 6 degrees of freedom. Tibia, patellar cut, and femoral cut, 3 cuts into 6 degrees of freedom means there's 215 ways in which a senior orthoplastic surgeon can get the knee replacement wrong. What to say about the juniors? A clear no if you have patients' interest in your heart, primum non sere is the first principle of ethics. If in doubt, ask. There's no shame. So hence this modern concept like robotics have come. What are the limitations of human eye? Only more than 10 degrees change in various fibrous angulation. I can detect less than more than 6 degrees change in various valgus angulation due to telescopic failure. Don't want bad in-office to affect outcome of surgery. Want minimize surgeon error. Many factors are at play. Some known, unknown, like ligament role. 1 millimeter accuracy is humanly impossible. Alignment versus balance issue not resolved in 2022. So we need robotics like Navio, Mako, Curvis, and Omni. What's changed? Change alone is permanent life. We have moved from 2D hinge knee to J-shaped pneumatic to transectional axis to what's called as a transcylindrical or the kinematic axis seen in the green. What's changed? West, the latest literature shows 3% TKR need early revision within 2 years. 20% of this failure is due to instability, as poor alignment or balance, or both, which are all surgeon errors. This leads to 20% dissatisfied patients after TKR. We know the old alignments like mechanical, implant-friendly alignment, but functional outcomes are inconsistent. It's probably dead as many people feel in 2022. Personalized alignment is what is coming now, aligned similar to natively, is kinematic, inverse kinematic, distributive kinematic, functional new kid in the these alignments. Just will say that the status alignment, quit inverse kinematic alignment is a robot, functional alignment, latest needs a robot, and balance. We know about the static measured precision, gap balance, dynamic balance, like sensors, navigation. What's new is combining robotic precision cut with the dynamic balance. Omnibot is the future, only robotic balance in the market with sensor-based limits. I've been doing robotics for the last 1 year in Bangalore. With 1 millimeter accuracy is possible. Less soft tissue dissection, no media release. Was surprised initially, but not anymore. Less pain and less blood loss. And early rehabilitation, doing 1 day before non-robotic patients. This is my first robotic, knee. You can see in the box left-hand side with the paper, the Proprietor robotics will be really proud of the flat line, which shows a perfect soft tissue balance from 0 to 130 degrees range of movement of the knee. This is a post-op X-ray. This is a patient who was able to not only straight the raise side, the immediate post-op recovery, but also have very conclude. Future is now robotic TKR is here to stay because advantage enhanced accuracy, reduced bleeding. MIS is possible. Functional alignment means soft tissue is respected as installed. Taught us 50 years ago, and the patients will do this possible. Faster rehab, better function. Soft tissue will come into the future. Walkway, reduce cost to reduce revision burden. Disadvantages, cost and burdens. Just a brief thing on the hip. The hottest topic in 2022 is the spine pelvis hip axis. In a risk averse society, both in the West and in India. This is a perfectly done simulated hip in the UK, got dislocated.
and then revised. And what went wrong is that the surgeon missed the patient at this point. So the spine, pelvic, and the hip relations become very important. I spoke to Dr. Davis, also of Robotics in Birmingham 6 months ago. I asked him, we illustrate this, and he said, Sri, it's still, cat is not over the back, still don't know what's going on. So simple is not easy, it's not good. Always look at this X-ray, looks good. This patient, another patient from UK, successfully mitigated from lumen discrepancy because the surgeon missed that there was a varus neck on the left side and went for unsymmetric implant, which goes where it wants to go. The quick and easy and more money for company is not easy on patients in view. The CKA 2019 months, 7 lakhs and losing crores. I have a lot of medical legal to work at conferences in some other fashion. We lost a case by MLAG in Supreme Court last week. We know all about this. And so the solution is OPS, which we discussed in Leeds. We get into that last time in robotics. These are the advantages of robotics. My take-home message is get it right first time, and robotics are important in evolving concept of plastic. Ensures the patients are legal protection. Demand is more from us in the future in a risk-averse society in India and the world. Training is a must to perform this complex work, acceptable standards. It has learning curve, and it's called experience. Pullman substitute is directional reading. We discussed in BHS in 2021 to get the link at the end. If there is a stiff pelvis, a hypomobile female, refer to the best orthoplastic frenemy, as they call it. Younger surgeons, I tell them don't perform by looking at YouTube or reviewing the videos. When things go wrong, we roasted just to attack relatives, as you saw 2 days ago in Orthopaedics. Popular saying you can in doubt, refer to orthopedic specialist, or command associate, a days of macrosurgeons. So these are the references for my talk. This is my last slide, but most important, please take a snapshot of this. For the authentic updates on these topics, the BHAC 2021 course in Basics of Clinical course from last November, December is available at SSOC.com. You can watch it. So, I end this topic here and I welcome questions. Thank you.
So thank you for that. Thank you for listening to this preliminary video come talk. Now we will start the proper program as it's 7 o'clock now. So let me share the remaining part of the slides. So welcome all again. I'll briefly go through the program details again. So we just finished the first video now, and the next part will be introduction of the faculty. So I'd like to introduce Dr. Harun Gupta. He's a consultant musculoskeletal radiologist from Leeds Teaching Hospital, NHS Trust in United Kingdom. And Dr. Harun has done MBBS MD and he's FRCR UK. So first of all, I'd like to thank him, for coming all the way from UK. Thanks, Harun, for your valuable time. He's a consultant musculoskeletal radiologist in Leeds Teaching Hospitals, and he's an honorary senior lecturer at the University of Leeds. He's a clinical supervisor for the Leeds Radiology Academy. So all the trainees who come, get trained by Dr. Harun Gupta. They've got a massive department, close to 100 consultants and close to 100 trainees, which is an amazing thing. The amount of clinical work they're doing and educational activities, just unimaginable, really. And he's also a clinical supervisor for the Leeds Radiology Academy. So all the juniors, particularly the registrars, go through Dr. Gupta. Dr. Gupta has already written a book on oncology, and we got Dr. Pradeep here from IMA, who is also an oncologist, and Sir has written a book on musculoskeletal oncology, which is a fantastic thing. Particularly, he's an expert in soft tissue tumors, which is brilliant. And he's trained in Aberdeen, and he did a MSK fellowship in Leeds before taking up a substantive permanent post in the Leeds. And he's associate editor of the Leeds Radiology Journal. He's a committee member of the World International Skeletal Society, European International Skeletal Society, British and Indian Musculoskeletal Societies. And last but not the least, he's my classmate. And we did MBBS together in Bangalore Medical College for 6 months in 1991. And then he decided that Bangalore was not the place for him, the better place like Mumbai and then UK. So, we missed it. So, right. So I think before I go to talking about the BHSC, I will complete my talk on artificial intelligence. I think it's a very, very interesting topic, and this is where the future is going to be. And a lot of people have been calling me asking, will they have their job in 3 or 4 or 5 years' time? I hope I'll be able to answer that in the next half an hour. So let me stop share this, and then I will complete my presentation. Then a brief video about BHSC. Then we'll go to the main topic of today. Right. So welcome you all, those who are joining through OrthoTV and those delegates who are here to this very interesting topic, artificial intelligence in healthcare, and particularly orthopedics. Is it a boon or is it a bane? This is a big question now. I think a lot of top guys are really trying to understand where exactly we are and what's going to happen. And, there are many fears and there are many excitement about it. So, and I'm somebody who believe in fundamentals and basics, and I'll take you right down to the basics of AI, because if we understand fundamentals right, then we can build superstructures on top of it. For those who do not know me, I'm Dr. Srikanth. I'm consultant knee and hip surgeon, and these are my qualifications. Particularly proud to have trained in Wrightington Hospital, the birthplace of joint replacement surgery in the world. I was formerly consultant trauma and orthopedic surgery, particularly joint replacement surgery in the UK. At present, I'm a proprietor and MD of Sarthi Specialty Knee and Hip Center in Gavipuram, Bangalore. I'm also consultant director at the Clinical Global Hospital, which is just behind this building here in Richmond Road. And, I welcome you all to the SSOC 6 Meet the Masters course, which has been a hybrid meeting. I welcome all all to our unit's second international meet. The first one we had, I think, in April when Prof. Acharya came here from Bristol, and we talked about Avengers in orthopedics. That's what Indian patients now want. They don't want ordinary surgeons; they want Avengers to come and bail them out. And we talked about augmented reality in orthopedics, and Prof talked about pelvic and acetabular surgery in a fantastic fashion. And I think all the juniors in India really appreciated his talk. For many people who don't know me, I will introduce myself. I trained in UK in all aspects of orthopedics and trauma. I have specialist interest in computer-assisted robotic knee hip surgery. I did a GMC recognized fellowship in remote teaching hospitals doing this computer-assisted knee and hip surgery and patient-specific implants. I have specialist interest in hip and knee sports and revision surgery. I did a fellowship in Avon Orthopaedic Center in Bristol, and Avon Orthopaedic Center is famous for the Avon knee. They have discovered this Avon knee. And my third fellowship was with, septic revision fellowships, that is infected revision. I went to Germany to train Prof. Gurka. He's one of the 2 world authorities in infected revision. And my center does offer quaternary referral service in India for these challenging patients where they get orthoplasty done, then they get infected. And sometimes they're diabetic and they've got a gram-negative sepsis. And it's almost impossible to get rid of gram-negative bacteria. And they all come to me, sadly, after burning their money with all the other surgeons in India. And it's very challenging, both as a patient and also financial part is very, very challenging. And these are the people, the families, they form a lifelong bond with me, so this is very interesting field of work. I did my UG and PG from the prestigious Bangalore Medical College Research Center. I'm quite happy that some of my professors are coming quite late in the night after their busy clinic. They are close to 80, still they've got busy clinics. So that is unbelievable, how, good practice they've got. I was a National Merit Scholar throughout, and I bring experience of more than 15,000 joint replacement surgeries over 14 years in the UK. I'm very fortunate enough to have worked in 4 out of 5 specialist orthopedic units in the UK. They're called a center of excellence because they've got the lowest infection rate in the whole world, around less than 0.03% infection rate, which is almost unheard of in this country at least. I'm a director of not only this course, but also the India and Southeast Asia coordinator of world-famous Bristol Hip Orthoplasty course. And again, I'm very proud to say that with the help of IMA, we'll be bringing this world-class course again for the benefits of orthopedic surgeons in India and Southeast Asia. And it's going to happen end of November, that is 30th of November and 1st of December, live from Bristol. And before I start, gratefulness to my teachers. It is said that Guru Brahma, Guru Vishnu in our old tradition. So my journey so far, the big ones. In one of the previous Meet the Masters course, we had this famous doctor who is on my right hand side, Professor Alistair Hart from London. He is known as the hospital hip detective by the British Broadcasting Corporation (BBC), and he's a full chair at the University of London, which is the largest university in the whole of Europe. And to my left is Professor John Skinner, who's the immediate past president of British Orthopaedic Association (BOA), and I'm very Prof Skinner was Prof Hart was very happy to present in Meet the Masters course about the future that's 3D printing in orthopedics, and my mentor also participated, and they had an exciting debate on the future of orthopedic surgery, which was fascinating. The second fellowship was a GMC approved fellowship in navigation and robotics. This was done way back in 2011, nearly 12 years ago. I've been at navigation and this kind of robotic surgery. And this is a presentation of fellowship by Dr. Jonathan Keenan, the director of orthoplasty at Plymouth Teaching Hospital. In fact, because of my passion in knee surgery, he used to nickname Sri the knee. This is a photo done by his daughter before I left the fellowship. Next is, I worked with Everett Smith in Bristol. He was a former UK head of European Hip Society. And along with Anthony Ward, they had this fantastic fellowship. And, it's been a fantastic, unforgivable journey since that time, really. So a fellow is never finished even after the job is done. So this is Everett coming to India for the first time, and this is the first Meet the Masters course, and I'm here flanked by my teacher, Professor J.K. Reddy from BMC, amazing teacher of orthopedics and other friends. This is the first SPARE approach, minimally invasive approach in India, being done at the All India Institute of Medical Science by Mr. Everett Smith. Again, a fantastic experience. Just before the AIMS got the new, fantastic, Beyond First World Operation Theaters, which happened a month later. My third fellowship was with Prof. Gurka. He's septic revision fellowship at Endoclinic Hamburg, Germany. He was one of the few single-stage revision surgeons in the world, along with Prof. Javed Parvez in US. So it was really great working with the prof and understanding how to put a new implant after infection. Worked also with, past president of British Knee Society, Mr. Richard Parkinson is my knee mentor, and he was the president of British Knee Society 2014 to 16, voted the top 10 best knee replacement surgeons and teachers in the UK. So my first job in UK was with him, way back in, I think it was 2000 really. So, and I've still kept in touch with Mr. Parkinson. That's the kind of relationship we have. Also trained with Frederick Lord. He's a pioneer of anterior approach to hip surgery. This is with Frederick Lord in Paris and Tours in his cadaveric workshop. Amazing thing about Frederick is he does hip replacement in 20 to 30 minutes, anterior approach, no assistant needed. So, so good for the patient, but bad for the fellows because they get nothing because he does everything skin to skin. This is at his cadaveric workshop in Tours, and I extensively train with the revision surgeons as well. Prof. Wayne Proprietor, he doesn't need introduction because all the acetabular defects is classified according to Prof. Proprietor, whom I met in Nottingham, and Dr. Lawrence Ahara and Jeremy Latham are very big revision surgeons in Bournemouth and Newcastle. Once, I went to see Lawrence Ahara where he put nearly 16 augments around the hip, which is very rare. I never seen any surgeon put so many augments really. So that is the complexity of the work, Lawrence does, and also Jeremy as well. I welcome all of you to BHAC 2023. Mentioned it's 30th November and 1st December. If you don't remember the dates, World AIDS Day is 1st December. So please do come. I will just share the link to register for this meeting shortly. This is the program list. I think what we are discussing about precision planning and execution in orthopedics, impact on the patient care and outcomes. What is good, what the difference I see in Indian practice and the West is that, yes, they do precision planning. We're also doing precision planning, but they look at the outcome scores and measures, and then they publish it, which is the key part which is missing in the Indian side. So once we do that, we'll be on par with the thing. So a unique thing about this particular meeting is that I'm a faculty myself, and I'm talking on two topics in the Bristol Hip Orthoplasty meet. So that'll be quite interesting. I think the invite from Evert I will play later on. Coming to today's topic, much awaited. A lot of people call me and said, "Sir, will I have a job in 3 to 5 years?" So let's explore this in detail because it's a very, very fascinating talk, really. So artificial intelligence in healthcare and orthopedics. I'm a consultant robotic reconstructive and orthoplasty surgeon at GGH Group of Hospitals, Bangalore. And let us see, artificial intelligence very useful in diagnosing many diseases. It's helpful in planning treatments. We know that it's helpful in patient education, medical research. So let's go back to the basics, because if we understand basics well, then we can build an edifice, a 20-story, 100-story, the building will not fall. But if our basics are poor, then, definitely the building is going to fall. So what is AI? So what is the definition of AI? So basically, it is intelligence demonstrated by a machine. What is intelligence? Intelligence is ability to acquire and apply new knowledge and skills to get new insights. AI helps to improve decision-making by doctors. It can summarize 10 pages of patient history, help analyze the symptoms and patterns, helps even patients make decisions. We used to talk about Google patient. Patients come to our OPD, they go through their disease symptoms through Google. Those days are finished. The Google patient is dead now. Now we have got the ChatGPT patients. Patients are going to ChatGPT, asking the AI what are all the things, and they are coming to with reams of paper to us saying, "Sir, this is what ChatGPT said. So what do you think you can do for me?" So this is the new thing which is happening, the ChatGPT patients. And we don't want patients to get too far ahead of us, really. And language is no longer a barrier. I used to look at UK, many papers coming in Chinese, I have to just reject because I can't understand Chinese. But now with the help of AI, paper published in Chinese, Mandarin, published in Hindi, published in Kannada, all will be converted into English, and then we can understand what's the quality of work happening in these countries. Big tech giants like Google are trialing AI systems like MedPalm 2 with huge neural networks with 1 trillion parameters at places like the Mayo Clinic in USA. The CEO of Mayo Clinic was on media just 2 days ago. He said the trial is going really well. It's very promising, but he has just shown cautious optimism in the use of AI. This is very important for business and hospital owners. Many of my hospital friends, colleagues, owners are here, and many said they'll join me. And because it saves a lot of money, if you have a receptionist, who's not very effective, who does repetitive job in your hospital, then you can easily replace the receptionist with the AI because it can do the same job that the receptionist is doing. Evolution of AI, the history. AI is not new. It's nearly 400 years old. It all started in 1962 when Pascal invented the first mechanical calculator, which is, excuse me. This mechanical calculator is the basis of the modern computers. It was as big as a brick size. 1940, Walter Pitts worked on neural networks and tried to make a machine which works like a human brain. In 1942, Alan Turing created the bomb machine. It's called as a bomb machine to crack the World War II code of the Germans, because the Germans had Enigma, and the Allies were trying to break that, and then they had this bomb machine. And Turing test in 1950s became a standard throughout the world how to test machines. In 1955, John McCarthy, the father, he's called the father of artificial intelligence. He coined the term the artificial intelligence. 1960 to 1990 was called AI winter because the grants for AI died, and there's no money, nothing can happen. And we faced similarly. We had a meeting, in North India, and then because of money we had to cancel it. And the grants are very, very important. So AI winter was between 1960 and 1990. In 1990, the cloud and semiconductor era started, and Maslow was a pioneer in this. And he described what is called as a Moore's law along with Moore, and this is a beautiful law. And he says every 2 years the chip halves in size, but the capacity doubles in size. A beautiful law, not proven wrong even till today. Every year, this law holds good. The chip is becoming half its size. The capacity of the chip is doubling, unlike human beings. It's just unbelievable. This is the bomb machine that Alan Turing worked, and after which the Turing law came. And this is the neural network done by Walter Pitts. They're trying to mimic the human brain into the computers and asking computers to do the same thing what human brain does. Let's go back to definition, the basic definitions. Is AI an algorithm? What is the algorithm? Algorithm is a step-by-step guide to solve a problem. It's a flow chart. What is AI? AI uses algorithm and is intelligence demonstrated by machine, which is self-led by machine learning process and performs tasks independent of human intervention. While algorithm needs a coder, AI doesn't need a coder. This is a fundamental difference. AI uses quality data, which is fed, and the machine learns to create new insights and newer ways of working. Data is the king, as you know. Data is the new oil, what we say in Middle East. What are the levels of AI? Nick Bostrom, is a professor in Oxford, and he has written a book called Superintelligence. He says there are 3 levels. The first level is artificial narrow intelligence. You give data, expect pattern recognizer, from the text, voice, or video data. This AI excels at a precisely defined single task, not multiple tasks, but a single task. And it can create a video from a text. So we are actually in 2023 in this stage. Second is artificial general intelligence. AI reaches human level of intelligence and can start reasoning, arguing, it can memorize, etc. This is at what is called as a Terminator movie. All of you have seen the Terminator movie. I grew up seeing the Terminator movie. So this is the Terminator movie. So where AI can reason, argue like human beings and fight, which is not good. So the third level is artificial super intelligence, where AI has the entire humanity's cognitive intelligence. That is AI as God. This you saw in a beautiful movie just released a few weeks ago called as The Creator. And I know if you've not seen that movie, it's a beautiful movie, you have to see it. So humans don't want this level really. So there's a blockade at UN level for work at this level, because we know COVID was unleashed, which country we know, and the world and its leaders were mute spectators. They are more reactive than proactive. So we have really interesting times ahead with AI. What are the levels of automation in healthcare? And any hospital owner, these are very, very important. Number 1 is human level. Doctor sees patient and intervention is at human level only. Okay. Second is the shadow mode, where doctor does all the work, but is facilitated by the AI, which shadows the doctor. In 2023, we are at this level. In the third level, it's called AI assistance, where AI is your companion at this level. You need to learn how to operate AI. And then fourth is the partial automation, where everything is done by AI. You just say good or bad at the end, so that AI learns through machine learning and it stores, okay, this doctor has said it's good, I'll store it, this is the right way to do. The last level is full automation, where 100% work is done by AI. There's no need for human beings. This is not a safe level. I don't want to steal thunder out of Dr. Harun. I know he's talking about AI and radiology, but there's one paper which shows that 1 radiologist with AI assistance equals 5 radiologists. Many of our radiologist colleagues are yet to join, so good that I'm talking before they come. Second is AI is everywhere. They are there in chat box, they are there in movie streaming, they are there in car parking, automatic number plate recognition, they are there in banking stocks, they are there in fraud prevention, they are there in autocorrect in our WhatsApp, it's AI. They are there in healthcare already. How does AI work? Learn, reason, interact. These are the basic principles of AI. It anticipates and does pattern recognition. Machine is fed quality data. All the data is in binary system. Computer works on 0 and 1. For example, a cat is a series of pixels for AI. And it uses the algorithm, and machine learning creates its own strategies, and we analyze and observe the results and say good or bad. What is machine learning? This is a beautiful picture. The cat is there, the tail is up, but this is converted into pixels. The pixel is converted into 0 and 1. So that is the binary system. The cat with the tail up is 0 to 1. It has got a particular data, and the cat with the tail down will have a different. If the cat looks like a cheetah, that will be a different one. So there'll be infinite possibilities, and AI can recognize these infinite possibilities and say, yes, this is a cheetah with the tail down, this is a cheetah with the tail up, like that. Machine learning. What is machine learning? The types of learning. One is supervised learning, like kids really. It's similar to how we trained as medical students. There's a data, there's a full history, investigation given, and even diagnosis given in the textbook. So we sort of mug it up and say, okay, this thing's pattern means this diagnosis, fine. So, but the same data can be given to AI, and you give them all investigation, but don't give diagnosis. Next time it'll tell what is the diagnosis. That is called as a supervised learning. That's the lowest level of learning. Second is unsupervised learning. AI uses algorithm to learn. Third is called the reinforced learning. Data is given with algorithm. It's called a matured learning. So result, say the human will say, is good or bad, and the AI stores that yes, this is the right way to do it. The fourth level is the deep learning, where the human neural network, it's based on human neural network. For example, if there is darkness, if you told AI put light, so if there is night, AI will put light. If suppose you come in front of the light and create a shadow, AI will still switch on light because it can't differentiate between the darkness which comes from the night to the darkness which comes because of your shadow. This is deep learning. So if you look at AI, these are all together. For example, deep learning is at the core. This is surrounded by the machine learning, that is surrounded by the neural nets, that is finally surrounded by the artificial intelligence. So if you go to artificial intelligence, the core of the artificial intelligence is deep learning. What are the subtypes of machine learning? This is important. There is a generative adversarial network called GAN, very, very important, how machine learning occurs. For example, AI starts copying a painting. Another, there is opposite algorithm in AI. It acts as a detective, find faults. And both of them try to outsmart each other. It's called as a zero-sum game. So by playing a zero-sum game, they learn, the machine learns and becomes perfect. This is called unsupervised learning. Then there's a federated learning. This is very important for hospital owners. There are many here. And all hospitals are collecting data. I think sooner or later, governments will demand hospitals to give the data. And hospitals can't refuse, but hospital can't disclose also because the confidentiality of the patient is lost. And if something happening in the hospital can be sued, because if it gets into the hands of the wrong people. So hospital AI here picks up a subset of data and churns results without confidentiality being breached and gives it to the government. This is a very nice way of doing. So this is called federated learning. What it decides what to share to the government. It's another machine learning method. This is the picture of the GAN, how it works. There's a generator and there is a discriminator. The generator is our painter and it keeps on producing painting and trying to fool the discriminator. The discriminator is our detective. It's trained on real data sets. Its job is to tell generator if the output is created is valid or not. They play a zero-sum game, as I mentioned. If the generator fools the discriminator, it wins. If the discriminator catches the output as fake, it wins. They teach each other in the process of unsupervised learning. This is how the real machine learning occurs. Why AI in healthcare is a game changer? We are in the digital age, whether we accept it or not. We can't manage terabytes of data. Big data doesn't need empathy, intuition, creativity, human expertise. These things are needed by a doctor and very important, but the big data doesn't need that. This can be given to the AI. AI can assist humans in meaningful interpretation of data, like these terabytes of data. Speed of analysis. Arteries AI is a company. It could diagnose heart disease in 15 seconds. Who can beat that? No cardiologist can beat that. And the quality of analysis. Checks XXWEX is another radiology AI company, which I shared with Dr. Harun. It can report 420 images in 1.2 minutes. They compared with human beings. It took 240 hours to report the same 420 images. So the speed is also, showing some benefits here. Then complexity in analysis, complex protein folding, like a lot of pharma companies, they do these drug designs. So this can be done in 100 the time as human beings can do. Then public health, this happened actually in real time. Canadian Blue Dot is an AI company from Canada. And, during COVID outbreak, they didn't know how many COVID patients had spread from China, everything. So they did use airline data to tell where all the COVID patients went, where they spread and everything within 5 days time. So which helped the public health. Finding unusual associations. For example, cerebrovascular accidents. You keep on looking at the retinal images and say, okay, this person can get a CVA. Or syndrome from clinical photographs of patients. You look at the patient's pictures and say, this fellow has got Marfan's, this fellow has got Down syndrome and things like that. Address doctor shortages. I was speaking to my lawyer this morning and saying this is the big problem in the world. WHO has predicted that 10 million doctors will be short by 2030. So doctors are precious resources. We can't really, stop medical colleges. We can't just de-recognize new MBBS seats at whims and fancies when we don't have doctors. If we had too many, then we could do that. This is what the regulators have to think. So waiting patients, because there may not be many doctors in future, we can use chatbots to address their basic questions. Then making quick decisions. For example, if you have the medical history, family history, investigation, and, medical data to predict, then, one can even prevent septic shock. in the ICU. So this is the benefit. And if the anesthetist is watching this program, this is something they need to pick it up on. You can use patient's voice to diagnose. For example, patient's talking, you can say this patient has got Alzheimer's. Cough, you can say this patient has got COVID. Or skin lesion, you look at it and say this patient has got this type of malignancy, which AI can do. And it can make doctor's life easy. My anesthetist is supposed to come here, Vidyanand. And we know ICU is a very, very noisy place. There are 200 alarms going, buzzing all the time. And 90% of them are considered to be fake. So doctors get, this bleep fatigue, keep on bleeping doctors again and again for silly reasons. Then they can't really understand which is correct. AI can give those 10% critical alarm to the doctor rather than 100% rubbish. So that will reduce bleep fatigue. Already the doctor's fatigue is a very big issue, both in the West and also in India. So let us give quality data to the doctors than 200 alarms, in the ICU. No more lab testing of drugs. Many pharma companies are here. We don't need human trials anymore. The silico clinical trial, you can do drug trial on 3D simulated models, thereby not making human beings as guinea pigs. Then self-learning, unlike human beings, it does not do mistake because there is self-learning, the GAN network, there's a checker and generator. That model is there, and it is said that the error is human. So what are the disadvantages and fears? Do I need to fear AI? No, I don't think you need to fear AI. You need to work with AI. Will it replace doctors? The answer is clear no. How does AI work? It's complex. You don't need to manufacture a car to drive a car, a Tesla. You just have to learn how to drive Tesla. That's all. You don't need to think, how do we manufacture Tesla to drive a Tesla? So just learn how to use AI. Can healthcare be automated? Already it is. How to embrace, play, utilize, and practice. If you're comfortable with AI systems, you are a junior doctor, my fellow, then you can even get better jobs. What are the ethical and social challenges? Somebody was discussing, I think Dr. Hegde this afternoon about the ethical issues with the AI, because he's done one paper on AI. So the important questions to be asked, like Google has come with this MedPalm 2. How do they handle the sensitive data, such as our medical records, our personal details, and our preferences? This is a very, very important, valid question. So what are the disadvantages or fears? Practical considerations. Doctors, we take time, to trust new technology. It's nothing wrong with that. Biases in AI. For example, if there's a derma cancer in a Caucasian, if the data is only fed in Caucasian, when a dark-skinned individual comes from Africa or India, so if it doesn't detect cancer, then that's called as a bias in AI, and that needs to be avoided by giving better data from Africa and India and other countries. AI has to pass evidence-based tests like all our investigations and new diagnostic tools. Data feeding error. If garbage in is garbage out. I learned this a decade ago with navigation, again with robotics, again same thing with AI as well. And there are doctor annotators working hard to avoid this data feedback errors. Privacy. Federated learning is the answer in future, how patient privacy can be protected. Cyber security, proper laws have to be passed. India cyber security is very poor. At least Europe has got a GDPR and things like that. Deepfakes, so can mimic you and your voice. So you need to find out and you need to avoid deepfakes. Mistakes and legality, can you sue AI or the company producing AI? Or is AI a tool like stethoscope? Can you sue at stethoscope? So I think, Advocate Ananya Joshi, who has joined us from Bombay, is the right person to answer it. I am not a lawyer. Philosophical issues, the black box paradox. We know the input from AI, we know the output, we understand that. But what happens within the AI and the machine learning? That's not clear. So that's like a black box. So input is known, output is known, but how exactly AI and ML are deciding, that is still, cannot fully understand. It's called black box paradox. Ethical issue. This is an AI trolley. I think even lawyers use this. But, for example, 5 kids are playing on a railway track illegally. Train comes regularly. There's one kid playing on a track next to that where trains never come, but the 2 tracks are connected. So what does a train driver do? Does he have to kill 5 kids because they are on the tracks illegally, where the train comes every day at 1 p.m., but still they are playing? Or should he divert his train, go and kill the child who is on the other track, who is not making any mistake because he knows train doesn't come here and is playing on the track? So this is a dilemma. What should the train driver do? Kill 5 kids or kill 1 kid who is not making mistake, or kill, whom should he save? This is called as the AI trolley. So AI faces that. And is AI conscious? Does it have rights? Does it have privacy? Can AI vote? Some European countries are passing laws to protect AI rights. This is where the world is going. AI in orthopedics, because I said that I'm going to talk about orthopedics, so I need to talk. There's not much really in this. I know many of my friends from Ahmedabad have joined. I really great respect to them. And, they were there with Meet the Masters program in the last few years. They have heard about Omnibot. Not many surgeons would have heard about it unless you've been following Meet the Masters course over the last few years. Omnibot, which we presented in, I think, year before, that uses AI and machine learning in robotics. None of the other robotic companies in India that I know uses, but soon they will catch up, because once one multinational starts using AI ML, the other companies have to just copy and paste to their systems and say, okay, we also got AI and ML. Robodoc uses artificial intelligence to drill femoral peg holes to put the femoral implant. AI can tell which patient will get 80% pain relief after TKR and who will get only 50% pain relief after TKR. This is the advent of personalized medicine or surgery. And I did a presentation here, and Dr. Mohsin was here, in the beginning of this year in the same hotel about personalized medicine, personalized surgery. That's where we are going. AI has reached human level of accuracy in fracture diagnosis in Sweden in a recent paper. AI as a second opinion to a casualty doctor, because casualty doctors are very hard pressed, particularly if you work in Europe, they're working all the time in the night, they can be tired and they might miss a fracture. So, but if the AI is there, it can say, no, there's a scaphoid fracture, you're missing this. Please, send it to the fracture clinic. Don't send them home, so it can tell. So it can act, let's say, like a mentor to these casualty doctors. OptoTrack 3020 uses AI-based infrared tool to find bones intra-op to put pedicle screws in the spine, or in difficult fracture to find the screw placement. I think those spine surgeons, Guru and others from in Delhi, joining, a very useful tool. Infrared, you can find difficult areas, anatomy, where is the pedicle screw, where is the nerve, then you can use AI to put the screw. We are discussing this part this afternoon in a lunchtime meeting which we had. Role of surgeon may get reduced to that of a pilot. What does a pilot do in a flight? He takes off, he lands, that's it. All the remaining thing is done by AI-controlled autopilot. So this is going to be the future life of surgeons. Take off and land. Which branches of medicine will survive? This is $1 million question. I will deal with it at a later time. But I'll tell you these principles that repetitive and data-driven jobs will go. Creative and patient interaction-based jobs will stay. Nobody AI can't touch that. Other jobs have got mixed results. You need to understand something called a Maravac's paradox. Very, very important. What's easy for you is difficult for AI, and vice versa. This is called Maravac's paradox. Nursing a patient, AI can't do. Reading complex CT, AI can do. A CEO runs hospital on standard operating procedures. A CEO can be easily replaced by AI. Very worrying news for all the CEOs of big hospitals and institutions. It's already happened in China. That CEO is an AI. It's replaced because it works on SOP. And nursing staff you can't replace the nursing staff. Still somebody has to do the hard work there, not just sitting and managing. How to retain your job in the AI? Again, $1 billion question. I would say embrace AI, then fight it. Doctors will not get replaced by AI, but there is a caveat. Again, I will deal with it at a later time. Multitaskers will survive. These are the basic 10 essential skills you need to have to survive in the AI era. If you don't have these skills, you're out of the business, as simple as that. At this juncture, I'm very happy to say that SSOC has started digital coaching. SSOC has invested in the AI, and we are getting AI Polaris, which will get deployed by this Diwali. And I'm going to name it as Deepak because giving light, Deepak. And as it's going to replace repetitive work done by reception or some junior doctors like my fellow who's still stuck and who couldn't join. So, these kinds of basic jobs can be replaced. And as doctors, one of the disease we have is that when we learn, we got so much of knowledge. We want to just mug everything and give everything, And this is taught from our MBBS days, And in coaching, we should not do that. We should only give what the other person can digest. You don't need to show, oh, this is the knowledge I got. Completely give everything, put it out, So SSOC is starting coaching in 4 main domains. One is for the patient or the common man. Second is for the junior doctor who wants to build his career. The third domain is for the common man whom justice delayed is justice denied. This is a big pain point in India, and several, probably half of the population is suffering from this. So this is where we want to come and make a difference to the Indian public. And last but not the least, the man looking for peace of mind and purpose in life. We want to start with that as post-COVID. That's very, very important. It's not just money making. So there will be 4 levels to this course: the silver level, the gold level, the diamond level, and the platinum level with one-to-one coaching. Further details, please log on to my website, www.srikanthkane.com. In landing page, in the banner on the top, there is a form one needs to fill, and my team will be in touch with you once you fill the form, how to take you through this digital coaching, which is very, very important and futuristic. The sign of intelligence is not knowledge, but imagination. It's what Albert Einstein said. So, I leave with that. I think this is probably going to be the future where man has to work with the AI and make friendship. And if there's any questions, I'm quite happy to take. So Dr. Mohsin, if you've got any questions, feel free. Mr. Zulfi, feel free. Dr. Gupta, feel free. Any questions you had, Dr. Mohsin? As a hospital owner, it's a beneficial thing because repetitive jobs done by reception and all, you can replace with AI very, very easy. Because we had a lunchtime meeting with some top radiologists in Karnataka and Bangalore.
The last picture, what I saw.
Yeah.
Yeah. You mean in the robotic?
It is a robot is one aspect, but artificial intelligence is a machine which can think for itself. And this is what we went in detail: how it thinks, how it learns, how it's called machine learning.
Robot is called as artificial.
It's probably not, because a lot of people are confusing robot with artificial intelligence. They're completely two different things. Robot is like a machine, and you can program it to do certain things. But in artificial intelligence, it has got the machine learning capacity. That means it can observe data and say, oh, Mr. Zulfi likes this. I want to do this way. Okay, because Mr. Zulfi liked that. But a robot will not be able to do. I program, I say, okay, cut this way, it will cut this way. That's it.
You mean to tell if there is a heart surgery is required, artificial intelligence is able to do it?
Yeah, it will be, because you have to say, you are a cardiac surgeon, you say, this is how I operate, this is how I like to operate. Then the artificial intelligence remembers through machine learning. It will say, okay, Mr. Zulfi is a cardiac surgeon, he likes it this way, this is how I'm going to do. But in a robot, it can't. It is like SOP, you create this is the manual, and the surgeon has to follow the manual. So whatever it happens.
We see a lot of videos, posters in Instagram.
Yeah.
The article, they play even shuttle, basketball, the same thing. They react easily as a good player.
Yeah.
Same you're telling, right?
Yeah, I mean, say a lot of there is like a mixture, and people are confused. And many, if you look at artificial intelligence, they only show robotic slides. But a robot is different, because I've been using robot for 2 years. A robot, you pre-plan something, you say cut this one, do like that, it will do. Some are automated, they can do the burr and things like that, but it can't understand what Srikanth like, what Dr. Gupta likes, what Dr. Mohsin likes. It doesn't understand. But artificial intelligence says, oh, this is a case of Mr. Zulfi, I'm going to operate this way. This is Dr. Gupta's this one, I'm going to do this way, because he doesn't like that. But this is Dr. Mohsin's case, I'm going to do this way. So it is thinking for you. So that that is the future where things are going.
So front office in administration also we can appoint them.
Yeah, front office, yes. So front office, because repetitive job, you do a call, collect money, that kind of a thing, it can be. It can talk, yeah. So I think that's where things are going. So that's all the repetitive jobs which are which can be performed will be replaced by AI. It'll be more efficient. It'll be loyal. There'll be no pilferage and things like that. So much more better actually. So we were discussing about some admin issues in one of the diagnostics in Bangalore, where they've been very bad to patients, send them away and everything. Those kinds of mistakes don't happen because of rudeness. It'll be polite to all.
Yeah, the lectures part also in the class.
It can, but yeah, it can. So yeah, correct. It can, but wherever that cognitive intelligence comes, like emotion, empathy, that's what I was talking about, Morlock's paradox, where you need to hold a patient's hand. Dr. Mohsin does that a lot. All his patients love him for that, because he's very empathetic doctor. That kind of thing the AI can't do, because it's a machine. So that there you need a human being. But other things, the routine kind of things which doesn't need a human emotions and empathy.
So this kind of artificial intelligence, like you're telling me, they can work as a human.
Yeah.
Exactly.
Yeah.
So is there any factory or hospital which is going on in the system?
Yeah, I think Mayo Clinic, MedPalm 2. They're using Google's MedPalm 2, Mayo Clinic. They're in very, very advanced stage of a thing. They're using advanced neural network also, and deep learning as well. And, I saw a CEO talking a couple of days ago. He's saying that they're showing very promising results. But, there's always a fear. They want to control AI to a particular extent so that it doesn't become a Terminator, or like there's a movie called Creator, which released last week. It's still running in Bangalore. It doesn't become like all God. AI should not become like God and decide what it wants to do against human will. So, yeah. But we're still in early stages. We are in level 1, level 2. There's up to level 5. So when we come to level 5, we have to be a bit careful. Okay, so I think I'll move on. So I'll stop sharing this, and I'll just go on to introduction of the PHAC, which is a very, very important meeting which is happening. And then after that, we'll have the best talk of today from Dr. Gupta from UK, which again on artificial intelligence. We'll have more questions at the end of it. I think my mentor, Dr. Edward Smith, was supposed to join me, but he had some other appointment. So he's been very kind enough to, send his invite to all of you, all the surgeons in India and Southeast Asia, to come and join us, on the 30th of November and 1st of December in the PHAC, breast lip orthoplasty course. I think I've been invited as a faculty, and I will be in the UK. Myself with my mentors, but all of you are most welcome to join at the click of a button. You can join from the comfort of your living rooms all the way and see what's happening in Bristol.
Hello everybody, Evan Smith here. I would like to welcome you all to join our meeting in Bristol, the Bristol Arthroplasty course this year, which is held on the 30th of November and 1st of December. It would be fantastic if we had a massive virtual audience from India and everywhere else in the world, as the face-to-face meeting itself is packed to the rafters. The wonderful thing about this long-standing boutique course is that it is extremely interactive, where we provide information which can be coalesced into knowledge. It is a great hip course and is made possible by my co-coordinators, David Penford from Clockwork, and of course the great work from Dr. in India. Please join us this year at the Bristol Hip Arthroplasty course. Thank you very much.
So I think, this is where, again, talking about future precision planning and execution in orthopedics. So there's a brief 5-minute video about these topics in detail. We'll just listen to that in a second. It just takes us through the history of BHAC, how it evolved and how it became one of the best hip meetings in the world, and what exactly we are discussing end of this year. So it's just fascinating, really. So I'm talking 2 topics at BHAC in Bristol this year. So that's something work I'm doing, and which I intend to do more with Dr. Mosley here. That will be one subject and one more interesting subject from the subcontinent. So please take a note of this, website, the URL. So to register this for this program, it's a very subsidized now this month till end of this month. From 1st November after Rajyotsava, the prices are likely to double. So please, I welcome all of you to register when it is quite cheap. Thank you. So now we'll continue with the rest of the program. So
Okay, sir. Can we end the session now?
no. So just one more talk is there. Just hold on.
Okay.
You can still see the screen. Can you see it now? You still there? Can you see
Yes, sir.
creativity corner? Yeah. Okay.
Yeah.
Okay. So yeah. So just we move on to we finished the BHAC. To log into this show, it is events.vidoctor.com/9FFJ. So I'm particularly looking forward to biomechanics of the hip and new alignment in sagittal and coronal plane in the light of robotics. Something that radiologists and orthopedic surgeons work together. So this is what we introduced during the Corona time, because there's a lot of wars and conflicts happening. As you know, the Hamas and Israel is at war now. and Ukraine and Russia have been at war, and we really try to understand what's going on in this world post-COVID, really. So that's why we started this creativity corner way back 3-4 years ago, and lateral thinking. We know that 20% of activities give 80% satisfaction in life. A 5-year-old child has 98% creativity versus adults at 2% creativity. This is from classic paper of George Land and Beth Jarman. When it comes to performance acceleration, the paradox is, for greater impact, we have to slow down enough to reflect on what we have done and where we are going. This is from the classic paper of Hegel, Wool et al. What COVID did to us, stop the world so that we get some time to think where we are going. Nearing 50 took this long for us to understand the meaning of human being. The being is a creative, wise, conscious self representing unity and oneness, while the human is a form of the physical world, and by its very nature has multiplicity, and unity is almost impossible because no two human beings are same or agree with each other due to the human ego. Thinking plays a subordinate part in decisive phase of creative work. Why majority of the scientists are not creative is not because they don't know how to think, but because they don't know how to stop thinking. This is classically illustrated by Archimedes. When he was in the bathtub, mind was stopped. He had this eureka moment. In that piece, he found the answer. And it's very important that as human beings, we need to find the stop button. Then only creativity comes out. Last year, we discussed about mirror meditation, very simple method to meditate. And, this year it is a 3 conscious breath, all that we need to do is, maybe set a timer in our iPhones, 3 times a day, like we do prayer, that, just have conscious breath. That is, breathe in, watch the air going in, sort of expanding the lungs, and, it sometimes goes up to the abdomen distance, and then breathe out. So then the abdomen gets pushed in, air comes to the chest and comes out. Just watch it. So when you consciously watch or attentive, awareness is there about breath, mind automatically stops. That's how the easiest method to get peace, because, when you observe, suppose you see a tiger or lion, you get fear. When you fear, mind is running fast, so you're breathing very quickly. But when you're calm, meditating, breathing slows down. So let's use this moment as an end to itself. In the last years also, I mentioned this. So this moment is not a means to an end, this is an end in itself. So this is the simplest definition of karma yoga that Krishna gave in Bhagavad Gita. And this leads to eternal happiness and also creativity. So regarding the war, subduing the false ego is the root of ending all interpersonal and international conflicts in the world. As they say, if you don't mind, it doesn't matter, So, let's not live for the world, live for ourselves, and let's make our surrounding better. That way the whole world will become better. So some science and metaphysics, one such talk on innovation, creativity in action is from our guest speaker. We are going to talk about role of superintelligence or artificial intelligence as a solution to our problems, at least in radiology. So I would like to introduce Dr. Harun again. Dr. Harun is a consultant musculoskeletal radiologist from Leeds Teaching Hospital, NHS Trust from United Kingdom. First, again, I would like to thank him for coming all the way from UK. It's a pleasure to have you here. And he's a consultant specializing in musculoskeletal. It's a separate kind, not that much developed in India, but in UK it's well established musculoskeletal radiology in Leeds Teaching Hospitals. He's an honorary senior lecturer at the University of Leeds, and he's a clinical supervisor for the Leeds Radiology Academy. He trained in Aberdeen and did a fellowship in MSK Radiology in Leeds and took up a permanent post there. He's an associate editor of the Leeds Radiology Journal. He's a committee member of the World International Skeletal Society, European and British and Indian Musculoskeletal Societies. Last but not the least, he's my classmate from Bangalore Medical College. We spent 6 months together, and then he left Bangalore to brighter and better places like Mumbai and then UK. So he's going to enlighten us on AI and radiology and in the training of the future radiologist. I met him personally recently at Leeds, and it was a pleasure to meet him with my son, who is starting his baby steps in artificial intelligence and radiology. In fact, I met Professor, from Oxford. What's the professor's name? What's the professor's name in Orthopaedics? Hemant Pandit, yeah, Professor Hemant Pandit. So I met him recently, and he's a full chair in the University of Leeds, and he's now sort of agreed to mentor my son in artificial intelligence, ML, which is going to be the future. So small world really. So over to Dr. Harun, podium is yours. I'll put up your presentation, and you can start the main topic of today, which is AI in healthcare. So just give me a second, Harun. Second. So I'll just go to play slideshow, and then it's all yours. Over to you from front and back. Okay, just down and back. Yeah, so you in the first slide. Thank you so much.
Can I start?
Yeah, please.
Yes. First of all, a very, very big thank you, Dr. Srikanth, for organizing this excellent conference. And I've listened to the talks till now. They've been very interesting talks. I'm glad that I'm able to contribute a little bit from the radiology point of view. And our message is pretty similar, but it will be very useful where I can add something about the AI in radiology, because in radiology, currently, AI is becoming a very big thing. And the radiologists currently are thinking again and again, what is going to happen to radiology in coming future. So the first thing, I think one main thing the radiologist currently, one big yeah. So I think one big thing, if you look at this slide, one big thing the radiology is seeing is the ever increasing change in the demand of radiology. If you look at this graph is from UK, and what has happened in the last 7 years, from 2012 to 2017, the number of CT scan and MRI scans have nearly completely doubled. So if you look at these slides here, this is the number of MRI and CT scans which are currently being performed in teaching hospitals and other institutes. So not only is the number of the imaging which is being performed, the CT scan and the MRI, more recently what has happened is the data acquisition and the volume of data has increased a lot. So for example, if we have a polytrauma scan, sometimes we have 1100 images to go through following the trauma scan, which is a huge amount of images to go through at one point of time. There's always sometimes a small place where error may happen during interpretation. And what has happened is because the demand is so much, nearly doubling in 5 years to 7 years time, the problem is we need the skilled human resources to interpret this imaging which has been performed. So we need enough number of people who can read these MRIs and CT scans. And not only that, what is going on is that we need more time to review these scans. And the other thing which is happening is the amount of data is increasing a lot. So the IT costs and the costs of radiology is going up. So if you look at the next slide, which looks at, we already know that the radiology is getting busier. We know more scans are being done. But the next slide shows that what is happening is the radiology is also becoming more costly. So the amount of, so what we need to run the radiology services, so the radiology, if you look at the last part, the radiology departments have got busier, but at the same time, the radiology department have also become more costlier in running the departments. So just to summarize what has happened in 5 years' time. So for example, in April 2012, there were about 250,000 CT scans performed per month in UK. And by 2019, the number of CT scans performed has doubled to 500,000. And the same thing has happened to the number of MRI. So the number of MRI were about 170,000 per month. And now 7 years later, these are approximately doubled to 320,000 per month. So there is a problem. Radiology is doing more scans. The number of scans are happening quicker. The problem on the other side is, where is the workforce? So if you look at the data from UK, it says that currently UK has about 1/3 number of radiology consultants short to do the work. And by 2027, rather than increase in the number of radiology consultants, there is going to be a decrease in the number of consultants by 2040 to 27. So you can look at by 2027, UK shortfall will increase from 29% to 40%. So the problem is, where do we get this workforce from to do all this difficult work? So there is no simple solution to do that. The specialist training in radiology takes about 5 years to do the specialist training. So, and then the specialist training requires trainers, and the trainers have to give up their time. So how can they teach all these things to people who have to learn? So, and the other biggest problem in the modern world, where the geographical mobility is very high, the big problem is staff retention, because staff can move to any part of the geographical world, and again affecting the workforce. So essentially, you see in UK, the data shows that the number of consultants are significantly falling down, but we have to run the workforce. How do we do that? Where do we get the workforce? And that's where a big thing is AI and teleradiology, which are coming up in big way. So I think Srikanth has covered the definition of artificial. I'll keep it simple. Artificial intelligence definition, it means where the basically cognitive function is developed. And that exactly is what the artificial intelligence means in simplified form. And whereas over time, when there is reasoning which is possible, and that's where the AI steps in. So what has happened in the last 10 years, where the artificial intelligence has become more and more important in radiology, is because of few factors. The few important factors in the last 10 years is that there is high quality annotated data available. So if you go to hospitals now, they have huge amount of digital data. So they have all over the place, they have data which can be used in future for AI purposes. And the other thing has been, there has been developing of deep learning algorithms. And the last thing which has happened is there is massive leap in the computational power. And all this has spearheaded the growth of artificial intelligence in the last few years. And then I think there are a number of algorithms by which artificial intelligence functions. And I think Srikanth quite nicely covered some of them. I've got a pictorial example. What I can say is that there is an article which was published recently in Clinical, Orthopaedics in Trauma. And I was also one of the authors of the article. It's open access article. So if somebody wants, they can go through it. And then it gives you all about the supervised, unsupervised, various changes happening in artificial intelligence. So essentially in supervised forms, what happens is both the input and the output data is labeled. Whereas as compared to the unsupervised form, the data which is fed is supervised, but what coming out is completely unsupervised. So over a period of time, what happens is, once the data is obtained, it extrapolates to what the abnormality is. Now, coming to a big impact of AI on radiology, what is happening in the field of radiology, you can see that nearly 5,500 articles have been published in radiology and AI in the last years after 2005. So you can see how important it is becoming. Everybody is discussing about it. So one of the white paper articles which was published by the European Society of Radiology in 2019 discussed three important things. And it's a very interesting thing. So they covered when the AI grows in future, the three important things will be the technical and the scientific side. So how the technology will evolve and how the science behind it will evolve. The second very important thing will be the ethical and the professional things which you mentioned. So what is going to happen? Who's going to take the responsibility when things go wrong? The last very important thing is the economic perspectives. So we have to know whether AI is useful. Is it viable? So what we also want to know is the economic perspective, whereas is AI cost effective? Whether we should really be doing, is it too expensive or is it cheaper? So I think this is a good diagram to look at what is going to happen in future. So a lot of people, when they think of AI, they think when the artificial intelligence comes, it's going to interpret the report and give the findings. Whereas an important part of the AI is that the AI steps in even before these steps have happened. So the important steps are so
just a bit of audio.
So a lot of people think the role of AI is only after the imaging has been done. Once the imaging is done, the AI will help provide the report. And that will be the report which will be useful to the clinicians and the radiologist. But a very big role of AI starts even before the patient has stepped into the scanner. So I would have divided, so what I've done is I've divided into three parts, the role of AI before the imaging has been performed, the role of AI during and while the imaging is being performed, and the role of AI after the imaging has been performed. So if you look at the role of AI before imaging, which is already happening, and a lot of practices, you would see that the patients get automated reminders. So in the West, loss of appointments is a very big thing. And because people are waiting for appointment for weeks to months' time, and it's a big waste of resources where the patient missed their appointments. So what AI can do is AI can look at this. It can find patients which have previously missed appointments. It can pick it up and it can make sure it keeps sending more reminders to these patients. And AI can also look at scheduling efficiency. It can look at different types of patient, subset of patients, where they come from, what is the urgency in the clinical request, and it can accordingly schedule the patient. The third very important thing in radiology is the scan protocol. So if somebody has asked for a particular scan, the AI can say, well, I think the CT is more appropriate in this case rather than MRI examination. That's some water. So AI can tell, and accordingly it can alert that, look, this is the more clinician, that the more appropriate investigation is this. The last very important thing is the use of contrast. So we should try and avoid using contrast where possible in radiology. Now, there have been some studies which have been done which says that the AI can read the request provided by clinicians, and it can tell whether in this case contrast will be required or not. And this is very useful because in some places the radiologist may not be there on site. So whereas AI can help here to say whether we should be giving contrast or not. The other very big thing which is happening in AI in radiology is during the imaging acquisition. So if you look at this diagram, here, what has happened is what is called as the deep learning reconstruction algorithms or techniques. And what these are doing is the typical MRI, the fastest you can do in about 15 to 20 minutes, which is the fastest. The patient stays still, that is the fastest you can do. But with deep learning algorithms, we're able to do the knee MRI in 4 minutes. So you can imagine patients, they're claustrophobic. Sometimes they're moving in the scanner. They can get into the scanner, they're out of the scanner in 4 minutes time. And if you can look in the image on the right side, this particular MRI with 5 sequences, which is of diagnostic quality, has been acquired in 4 minutes. So AI, because of these deep learning algorithms, will significantly accelerate MRI acquisition. So what will happen in future is, for example, an orthopedic surgeon, rheumatologist, sports physician, GP, they see the patient and they think that there is urgent need of MRI. The patient will be able to walk into the MRI scanner like X-rays. So like X-rays are being performed, MRIs will be performed like X-rays. So you can imagine that will have a big impact on patient management. So you get the results immediately. The next very big area I already mentioned, because sometimes because of long acquisition, the patient become claustrophobic and they start moving in the scanner. And that is a big problem in MRI. The patients keep moving. And when the patient moves, it deteriorates the image quality. And you can see on the right side, what AI has cleverly done by using different techniques such as parallel imaging, compressed sensing, variation network, it has removed those artifacts. So despite artifacts being there, they have been removed. So that will become a very big thing again for image acquisition. The quality of imaging will improve. And the third thing which the AI can do during imaging is it produces super resolution. So at the moment, we have to use at least 1.5 Tesla MRI scanners or 3 Tesla MRI scanners to acquire good quality. But what AI will do is AI will produce super resolution, and we will be able to do MRI using low strength MR. So once we use low strength MR, the cost of MRI machine will fall significantly. That will also decrease the cost of the MRI. The MRIs will be done faster. And these MR, for example, the low signal one, they are very easier and cheaper to maintain. So I think we will all be going towards X-ray. The MRIs will almost be used like we use X-rays at the moment. And a very big role of AI is post-imaging acquisition. So what, if you look at 3 words here, pre-read, categorize, and prioritize. So once the MRI is done, the AI will read that MRI. It will triage that MRI and categorize how urgent it is. Is there any important finding? If there are any important findings, it will prioritize it at the top of the list. So your PACS, where you have the radiology information system, will become very, very smart. Things which are very important will come right at the top with a message that this is important to report. So this is going to be a big thing, because what is happening is, as I already mentioned, especially in West, we are doing thousands of MR, thousands of CT scan. We don't have the workforce to report them. So what AI will do, AI will prioritize them and triage them and tell us that these need to be dealt with more quickly. So that will become a big thing. The other very important thing AI is doing is called as augmented reading, which is called as, essentially it is helping the radiologist read the MRI. So it produces an augmented report, and then the radiologist reads the MRI, and then it helps us, the report becomes more cleverer and better. So when we are reading the report entirely on our own, we have to rely on looking at the whole MRI. And sometimes, because of satisfaction of search, sometimes the radiologist can miss small important findings. And with the presence of AI, I think that will become another very big help, which will augment and give us more findings. And other important thing is that in radiology, everything is moving toward structured reporting. Knee, spine. So there's a whole structure of the report. With AI, when it generates the report, the whole report can come in the form of structure. And that again becomes very useful for the radiologist. The another area which is upcoming in the AI, apart from all this, is called as radiomics. And this is becoming a very big area, especially for tumors, bone tumors and soft tissue tumors. So what happens is when the images are required, the small pixels and other things within the characteristics which are invisible to human eyes, the AI can read all that. So in cases of tumors, they can find different characteristics in these bone tumors and soft tissue tumors, and they will be able to give more information, not only during the treatment, but after the treatment as well. So any important comparison change is happening. And this is another very big field which is developing with artificial intelligence. So essentially what we are developing in AI, you've seen pre, during, and post. And we also looked at radiomix. And what radiomix will do is we will be moving towards precision diagnostics. So the reports will become cleverer, better, quantitative, and very, they will give all the findings. So once we have precision diagnostics, we will also move towards precision therapeutics. So what is the exact treatment that is required for the patient? And essentially, once the best treatment is given, we will also be able to give the best prognosis to the patient, the best outcomes to the patient. I think this slide is pretty much a repetition of what I've already said, what AI is doing. AI, essentially, we have all the data at our fingertips. AI will also prevent, it will look at what tests have already been done. For example, I'll end up, I give all my details, it will already be able to scan the system that I have already had these particular scans. I don't need this scan. So it will avoid that duplication if there are multiple requests coming in for the same patient. We already looked at the ways it's going to save time and money. It will also help us compare on the system with any previous imaging. So previous imaging is a big thing. And if there are any previous imaging on the system, it will help us compare with that and give us an augmented report. Again, looking at the cost, there will be no films. We don't need any films. It's all digital data. So all the costs will come down. And there will also be things like data mining, research, which is a big thing. And it will also be, a lot of other parameters, factors like patient's age, weight, different things which are available. AI will be able to use all these different things and will be able to give us more information for future, which is very useful for research. We already looked at reduced scan time, patient compliance will be better, the image improved quality will be much more improved. We already looked at the AI categorizing everything, making it a smart packs. So we are able to give quick reports for urgent patients. Any urgent findings are there, they will be able to be conveyed much earlier. And in some places nowadays, there are ways where immediately the scan is done, there is important finding, the report is done, the report is immediately conveyed to the clinician. So you have immediate ways of texting, email, alert. The report immediately goes to the clinician that, look, your patient got a fracture or the patient got an infection. There is an important finding. And not only that, with AI, I think a number of things which are going to happen locally. So, so when the report comes in, say one report has come in, there is an important finding, all the key images of that finding can go along with the report. If I say in the report, there is presence of a fracture here, that image with the fracture can go along with the report. The clinician can see what exactly I'm talking about. The other thing is the language, which is a big thing. The reports will be generated in the language which the patient can read, they can understand. And once they have that, they will become more and more involved in their own healthcare and own healthcare management. So obviously this gives patients more choice, it gives patients health in their hands. So overall it's good for the patients. I think you already mentioned about the insecurities. So a lot of insecurities are there. I keep hearing in social media all the time where, a lot of people worry that the radiologist will be replaced in future, but that is definitely not the case. I think radiologists will have to learn with artificial intelligence. So what a number of studies have done is where the radiologists work with the artificial intelligence, the clinical or the patient outcomes are far better. The reports are far better. Our working lives definitely will change with AI, that we have to accept. And we have to accept that there will be large volume scans, but we will be able to do things faster, and we will be able to do things much better. So in summary, there is no doubt that AI will disrupt all the imaging, and it will also disrupt the way we interpret the imaging. We will have augmented reports where we will have reports which is given by the AI, and then we will look at the images, and then we will be able to give a collaborative report. But while we are giving collaborative reports, the AI will keep learning as well. And when we make any changes in the AI, we tell AI that, no, this is what I think, then they will keep learning more and more. So over time, it will keep getting better and better. We've already looked at accelerate MRI, where the MR times will become significantly shorter. There will be possibility of walk-in MRs like walk-in X-rays. The reports will come out quicker, and immediately the reports can go to the clinicians. Patients' communication, as I already mentioned, will improve, and we will move to a more quantitative report. So everything will be more precise reports, leading to more precision in therapeutics, again, because of AI, with all the ways you mentioned in orthopedics and surgery, and then more precise prognosis, because everything is very precise now. The report's precise, the treatment by the orthopedic surgeon is very precise, the prognosis will be far more precise. So a big acknowledgement to one of my colleagues, Siddharth Thakkar, who's currently a consultant in Leicester Teaching Hospitals. And very quickly, I would like to tell, it's not to do with AI, but this is a book which I've written, and this has been released early this year. It's a practical guide for imaging of soft tissue tumors. A lot of books already exist in the market, but they are encyclopedic, and they don't have the current imaging, because the imaging has changed so much over the years. They contain all the older images, whereas in this one, we have simplified everything. It is very handy book. All the things are according to WHO classification. There are chapters according to histopathology, biopsy, and post-operative imaging. So I would certainly suggest, if anybody is looking at soft tissue tumors or they're involved in the management of soft tissue tumors, definitely have a look at this book. So a big thank you to everybody for listening and for their time. And I think AI will be very, very important in radiology in future.
Thank you for a fantastic talk, Dr. Harun. I'm very happy to share with you that there are 803 doctors watching us online. In the last 6 years of my history doing this is the highest number. I never crossed 500 live views. So today your speech has brought more than 803 people who are watching online. So thank you so much for a fantastic talk. So we'd like to hear the next part.
No, I'm very grateful, Dr. Srikanth. I think it is a very interesting topic, because wherever I go now, people keep talking about AI. So I've tried to simplify, you've tried to simplify as much as possible. And I think very quickly, I will tell us very quickly, I won't take a long time, about one of the projects which I have started recently. It's called as MSK Teaching Room. And essentially, it came to, I had it for a long time, because I've been a consultant for 15 years. And we see so many cases in our practice. And I was always thinking of ways where we can have some kind of DICOM data cases, and we have all the expert reports, and where we can put things together. And especially after COVID, I felt we can have a platform where we can teach people globally. So with this in mind, I built up this with the help of a few of my colleagues, which is called as MSK Teaching Room. So why I have done this, we have looked at AI. AI will do a lot of things, but the radiologist will still need to learn. Means that the car can be driven by technology, but if the technology fails, the driver still need to know how to drive it where things go wrong. And the radiologists, therefore, they will need to learn a number of skills that won't go down. And I personally feel that there's a need for quality training resources across the world, especially in different continents. And India is one place which is upcoming. Previously, 20 years back, for example, when I was training in Mumbai, in 4 institutes, there was 1 MRI scanner, 20 years back. Now, when you look at India, 20 years later, there is pretty much MRI at every corner. The MRI quality, there is a 3T scanner, which is available all around. In fact, I would say that we have more 3T scanners than developing world at the moment. So the equipment has gone so high, we have people who want to learn. So it was never about lack of people learning ability. I think it was always about the equipment not availability. And because the equipment wasn't available, we didn't have enough trainers. People were always there willing to learn. And now we have all that. We have equipment, we have people who are willing to learn. So I think there is nothing stopping us to becoming one of the best in learning at the moment. So as I've already said, the equipment is available. And one thing which I've already seen problems with training, especially in developing world, is that the training can sometimes vary where you learn because of geographic factors, economic factors, equipment factors, and the trainer factors. Learning barriers are there. And then already I'm saying, I've said the competition is coming up. This is the era of AI. So with all this, we have kept this in mind and built something which we think we can overcome all this. So with this in mind, we introduced the MSK teaching room. It's an innovative program where we have made a vast library of full DICOM cases. So it's musculoskeletal MRI cases at the moment. And it's almost like real life learning for radiologists. And it's a one-of-a-kind product developed by radiologists, all based in UK and Europe. So these cases, these are actual cases. They have different pathologies. And these cases, when we go to the platform, can be seen completely in full. There is a reporting template. You can write your reports in that. And most importantly, when the report is done or when you write your report, you can compare your report against a validated report. So what is the actual report for the MRI scanner? And this is exactly the way we teach our registrars, our fellows, where they do the first read, they write the report, and then we look through the MRI, and then we tell them these are the changes, and this is the way they learn. And we also plan to put video lectures and other video findings of the cases. And we're also trying to collaborate with one of the best radiologists in the world. So I think with this in mind, we want to build up one of the biggest libraries in the world. We're already trying to partner with one of the best radiologists in the world. And the whole product is completely GDPR compliant. And essentially, we want to bring technology. We want to bring technology to that level which can be used by everybody. So what are the target audience for us? The target audience is trainee radiologists, is general radiologists who want to learn MSK radiology. And finally, we're getting radiology fellows who are one of the best, who wish to learn from the best experts in the world. So important thing to remember is the world is getting smaller. There is a demand for learning from the validated cases. And do remember, currently we have increased number of teleradiology happening in the world from different parts of the world. And this is important. Whereas because if people can learn from different cases, sitting at their home on demand, they will be able to do teleradiology much better. So people are giving FRCR exams and they haven't even traveled abroad to UK, and they will be able to report UK cases because they would have gone through these cases. They would have seen what the typical reports are like. And once they have done that, their confidence of reporting scans for US or UK sitting in India will be far higher. So in future, we also plan to start online fellowships, which will help people learn the CPDs. And overall, I would say it's an innovative platform. The cases, there are innovative cases according to different body parts, according to different pathology. And so over next year, we hope we will become one of the largest MSK libraries by next year. And overall, our overall aim is that we become a big center and we're able to help as much as possible in the learning of MSK radiology. And this is the platform we are using currently for MSK radiology. It's called as Collective Minds. It's a Sweden-based platform and it's completely GDPR compliant. It follows all the rules and the norms which are followed in European country. So all thank you very much here.
Just GDPR is not well known in India. Just briefly, 2 or 3 sentences summarize what is GDPR.
Sure.
Most of the Indians understand. Generalized data protection, some regulations. GDPR, you can just explain to the Indian audience what is GDPR.
So what has happened in Europe over the years is data is always a big issue, and how the data is shared is an even bigger issue. So currently already the European norms mean that data cannot be transferred out of European Union very, very easily. And that is why we come up with a new policy which is called as GDPR compliance. So that means this is once you have compliance, that is the only structure under which you can share the data. So that's why if you're doing any project which doesn't have compliance, it can be a big issue, how we use that data. So I think that's why we have partnered with a company which is based in Sweden and which have all the GDPR compliance. If you Google, it will give you, it's a very strong thing for this. Anything which we use about any patient, we have to be very careful. We have to make sure that we have all the valid permissions. So in that, there are a lot of things. You have to think whether data is really needed, whether data needs to be stored, how long the data should be stored. Should we just destroy it once it is stored? And all these different things come into play.
So IPL, as you know, is a big craze in India. So we had Dr. Srikanth here who already is treating IPL patients. So recently we had Kane Williamson, who had a hit in the hand fracture. This 4-minute MRI. So how can we get it? Is it already available in Europe? Or,
it is gradually coming up. So what is happening in different hospitals? They are doing these kind of MRs, and they are asking the radiologist, how happy are you with the diagnostic quality? So, it just obviously varies. Some centers which are ahead, they're able to produce far better quality as compared to the other centers. But in US, this is coming in big way. And I think there is no way we'll be able to escape it. I think this is gradually, with the new sequence, it is going to become very common.
Radio mimics.
Sorry?
Radio mimics, you mentioned about early tumor diagnosis, the new thing which is coming up. It's radio mimics, is it?
Yeah, the radiomics is a new field. So what they believe is that when the image is acquired, the images have so much pixelated data, other things within them, other things, which is invisible to human eyes. So all that data, they believe that the computer and AI will be able to pick up. So especially in soft tissue tumors and bone tumors, which can be quite difficult, complex cases, in these cases is going to have an important role to play. So currently that's where they're using it. Once the scan of the tumor is done, they're able to get all these pixelated data from it and then analyze it. And in future will be able to help us give diagnosis, prognosis and management.
Either questions or mostly you got any questions for whether you got any questions?
Yeah, please come forward. Please come forward. Don't agitate.
You told the reports which are generated by reports, simpler language which patients can understand. So based on that, patients definitely will take the simpler understanding report and they put it into other AIs, in the medical system. Like they put it into other AIs like ChatGPT.
Hello, sir.
Can I mic? Sorry.
Hello.
Sorry.
Can you hear me, sir?
Yeah, I can hear you. Can you hear me now?
Yeah.
How do doctors deal with it? Doctors deal with it.
What's the question, Dr. Raman?
The AI which is patients will get a simpler report, which they understand. And they put it into other chat GPTs, and they get better, better management to their body. Definitely the patients are their own. They are the best analytics of their own body. So they try to search for the best things which suits them. Doctor might not think like that. Doctor might think if the patient, this is a patient, this is the case. That's what we have learned, and this is the thing we have to do. This is the protocol we'll go. But the patient doesn't go by the protocol. He looks at all the options which the recent year, and he comes up with something and starts treatment on his own. Maybe medical, I think he'll get all the medicines online. And so what does doctor has to do next? It's so scary. I don't know what to do.
Oh, I think doctors will have a very good because see what the AI is doing. AI, if you look at the way it is going to do, it is going to produce a structured report, very detailed report, and it will produce so many different findings, incidental findings, every small thing. You can imagine how complicated it will be. So they may have a CT scan with hundreds of findings which are not important. Whereas doctors look at the labs of patient symptoms. What is the current? What is the reason? We can look and tell because of cognitive what is important. Simple it's smaller than that. What is the conclusion? You will be able to guide and say what is the most important point. Patient's presentation. So I think doctors still very important. But I don't think there is a way where
that's very interesting, sir. We can increase based on the patients.
What's the way the doctors will help is, as I said, is because the number of scans that are happening will increase a lot. We will not be able to cope with it. Already CT scan, the MR, trauma scans are happening too much. Even if say in India you are able to report so fast and so many scans, first of all it's tiring. Secondly, the number of mistakes in the case. So if you start reporting say 25, 30 scans very quickly, then there are two chances. You will get tired by the end. And maybe you're younger, you can do as you get older, it's very difficult. The chances of miss will be very, very high. Whereas in these cases, AI becomes your assistant. AI becomes your assistant where it does the first review, and then you go through it, and then you produce the report because of the medical knowledge, past experience, past mistakes. So that's very important.
So thank you very much.
When my follow-up question on the same thing. After getting the reports with so many other things which are consultant, patients might go the other way also. Because it might be irrelevant for me being an obstetrician. I see a fracture of my patient is coming with the same symptoms. All good, all fine, everything is good. But maybe the report generates a small cyst, maybe like a valve or dysfunction on the leg. With for the patient, which is irrelevant at that point. But the patient starts treating for the irrelevant conditions. So if it goes at the genetics level, the scans go through the genetic level and find some gene is missing, some gene which is predisposing to cancer or something. Patients might go the other way and start worrying about that, which is not needed at the moment. So how do we control that?
See, first, most important thing is we cannot stop the patient from doing what they do. Already patients have social media, they have internet, there is other technology where they can search things. Which as a doctor and as a radiologist, we can only guide and give the best quality reports. What is ethical, what is important, we put it down, and what is not important, we guide the report accordingly. So then there are other different findings. It does happen even now, even in the West, where we like land up finding a lot of incidental things. And sometimes we have to investigate them. But some things are not important, but some things we can guide that we have found something like like something in the thyroid, in a scan or something. In some cases, we have to investigate them further. But I think our job will be that we, triage the things which are found. We say what is important, what is not important, and we ethically guide the patient. Typically speaking, we cannot stop the patient. We can only guide them. We can tell them what is the best thing. But if they still want to keep every word, there's nothing, no way, and we can stop them from that.
Okay. Yeah, thank you. Thank you.
At the end of the day, all depends on what type of relationship you develop. So at the end of the day, it was a very nice meeting you. So at the end of the day, when I have to conclude this talk, it says what type of relationship you have with the patient with respect to whatever artificial intelligence, whatever you say, and it's a patient who's going to believe another human being sitting in front of you, then to believe a computer for you to decide what you have to do.
Absolutely, sir.
And whatever said and done, all this can be only a supplement. It can never replace doctor.
Empathy can't be replaced. Yeah, that's true.
Apart from the FPS, empathy the most important. And secondly, it is a personal touch that you have with the doctor. And that amount of compassion that you have when you go touch your patient and say, don't worry, you're okay. I don't think
machines can't.
You're going to read the report and say,
Exactly.
yes, I got it.
You hit the nail on the head.
So we should really not fear. Yes, it is definitely going to aid us to what we studied. Many a times I felt saying that I really wish computers were there at the time when we studied. It would have been so simple. I don't think we would have had to slog so much to study. Though. We used to study till 12 o'clock, 1 o'clock in the night. You have to do MBBS. So you are the younger generation. Definitely you are in a better state.
I think what you're saying is very true. Experience, what you've trained in the years, you're able to provide assurance on this.
Assurance to the patient.
I think that's what they're doing with the patient. Still wants to go somewhere else and do it, we cannot stop them. As long as we are able to guide them in our experience, tell them where we don't know what's about. But I think ethically we can only guide, reassure.
Thank you so much, Dr. Harun. A round of applause for Dr. Harun for a fantastic talk. So thank you very much. So so I think we'll carry on because the online they are waiting for us. So thank you very much. My fellow had a very complicated questions. I call him as a chat GPT fellow. So he's from the next generation. So we are from the older generation. So it needed a longer answer. In short, Dr. Raghavendra missed my presentation. So I was telling how AI is going to impact orthopedics. And I think what orthopedic surgeons need to learn is empathy. They need to learn bedside manners. That can't be replaced by AI. So that's where the human strength is. So where human strength is, if we develop, like Dr. Mohsin said, empathy, bedside manners, all those things that can't be replaced. If we just go completely technological, so that's easy for AI to replace. So thank you very much. I'm really honored that this talk. I was looking at OrthoTV also online while Dr. Harun was talking, and there are around 800 plus delegates who are watching online, which is, I think, the highest record for all the 6 years of this work I've done. It's never crossed live more than 500, but today's special talk from Harun, it has crossed 800 plus, which is fantastic. So I think I should really congratulate Dr. Harun for that, and OrthoTV and the whole team there in OrthoTV behind this. This sort of reinforces my belief in technology, because I've been doing this since 2016 or 17 before COVID, and strangely it reinforces my belief in artificial intelligence also, because it's no nonsense. It is not as complicated as human beings. So I'll come, I'll not come, that kind of a thing. You just ask it to do some job, it'll do. And you can 100% trust that. So that's fantastic. I think we are now to the last leg, and this is the, I think, two fantastic talks today. But I would not say that this is the last, but not the least talk, because this is very, very relevant to every Indian, and this is very, very relevant to every doctor practicing in India, because the legal systems are very complex, the regulators are very complex. So that's why this talk. We know medicine and orthopedics continuously evolve. As doctors, we expect the rest of the society to evolve with us as well. So only you can't expect doctor to be perfect like a god, but you can do whatever you want to do. That is not acceptable for doctors. As doctors, we are harsh on ourselves, to help our patients. So when So when we are harsh on ourselves to improve, why the rest of the society can't be harsh on themselves, to improve, to make life of the common man in India better, So we expect as doctors that the rest of the society also behaves ethically and correctly, work hard, don't escape and that kind of a thing. So they say ignorance of the law is not an excuse, but law itself, is so complicated, and Greek and Latin, even to the most educated like doctors. I'll give a real life example. I think most of the doctors in India know about this. We had an unfortunate suicide of a young doctor, a gynecologist, and this happened sadly in Rajasthan a year or 2 years ago. I think most of the people in India know, particularly Rajasthanis, know that more well. And she was put on a false charge. I think she was practicing in Jaipur with her husband, and a young couple, and fantastic work, more money in Jaipur. But husband, a very idealistic doctor, he said, "Oh, my village, let's go to my village and practice." So she also moved with her husband. They had a little hospital of their own, and this patient had such complication in Jaipur and postpartum hemorrhage, so neglected in Jaipur. Neglected means sent away from Jaipur, a city, to the village. And they came to her because of trust, of the faith that they had in this doctor. And needless to say, they came so late that both the child and the mother died or something. And the police straight away put 302 murder charges on the doctor. And she was so fed up with everything what has happened, she committed suicide. I mean, this is a tragedy, completely tragedy. 302 can never be put on doctor of doing his job, his duty. So this is what happened. And then we don't know what happened to the police and the babus who brought such a cocked up charges to pacify the crowd who had arranged come at the hospital. They want to crowd control. So put 302, put doctor behind the bar. This is what happened. So here also the ignorance of 302, that 302 can't be bought on a doctor as per the Supreme Court law. 302A is there that can be brought, but not 302. So that ignorance also led to the suicide. If the doctor is aware, hey, I'm doing my job, patient die, I'm not a murderer, I'm trying to help here. So, go away. So to the police or to the babu or to the lawyer or to the judge, then the doctor would be alive today. But, she committed suicide thinking this is true. So that means even as doctors, we are ignorant of the law. Also, I had a very close friend, who had a corner site here in Bangalore, and it got encroached by 300 square feet. And after 8 long years of litigation, justice delayed, as they say. It was ruled that there was no encroachment. Despite all the documentary evidence to the contrary. Yes, the High Court of the Karnataka may be a vaccine to this, but what is the vaccine for corruption? We need to look at that also. What is the vaccine for corruption? So the common man, the doctor also, we are all common man because we don't understand the law. He's baffled as he doesn't know the law. He doesn't know what recourse. So this becomes the most important talk of this evening. Regulating the regulators. That's why we put this thing, regulating the regulators. So how do we regulate the regulators? How to know our rights under our constitution? Because constitution is Mabap. It's ultimate in India. For the netas, for the babus, for the judiciary, for the police, and all of us. Constitution is supreme, and all of us have to follow the constitution. Okay, so nobody is highest here in the country except constitution. So such talks will help find solution to what 50% of the Indian population suffer. Some of them are pendency in our judicial system. So let's listen to this last but not least of the presentation, or to Advocate Ananya Joshi from Bombay. She's not only advocate, but a good friend of mine. So quickly introduce Advocate Ananya Joshi. She's a Bachelor of Arts and LLB. She's actually originally from Bangalore, and she has done LLM in health law, and she's quite an experienced lawyer, and he's got good experience in providing support to medical institutions and medical professionals in all medical legal aspects, including business related and also medical legal litigations. If you're in soup as a doctor, who should be your friend. So, just over to Ananya. I'll just try to stop share, and I think she's already on the Zoom. I'll just ask Ananya to sort of unmute herself, and then, then she can talk. I don't think she has got a presentation, so I'm just going to ask her to request her to unmute herself, and then, yeah. So, Ananya, I think you're muted, so you need to, yeah, now I can hear.
Can you hear me?
Yeah. Thank you.
Yeah. Hi, Dr. Srikanth. Thanks for inviting me. And hi, everybody else. So I have done my master's in health law, and just some time back, Dr. Srikanth mentioned, can you sue AI? So that was something that really caught my attention, actually. I know the topic is mostly regulating the regulators, and the topic that you had allotted to me as of now is NMC and what is exactly inside of it. But so you mentioned about stethoscope. Can we sue a stethoscope? But it's not the stethoscope that we will be suing. The patient or the patient party can sue the company that has manufactured it. So even in AI, I'm aware that there are a lot of institutions, companies, mainly startups that are coming up, which are which have a really good expertise in AI related software, especially radiology, X-rays, and that is also there. Nobody is going to lose the job, like what you're explaining in the previous session. It is just that there is one person, who the radiologist, who has to uh, you know share the actual remarks. So even if the AI is going to give all the checklist, it has to be signed by the doctor. So that is the requirement, right, as of now. So that is always there. And it's also about calibration and everything, which is governed under Medical Device Rules 2017. So maybe that is for another day, a topic for another day, when AI in medical industry is booming even more than what it is doing right now. And this Digital Data Protection Act, which has already been in action. And let's see how things go. But for today, I will just start with the brief introduction of NMC. And I'm not really sure what are the questions that are going to come up, but I will just start with the introduction so that we can go ahead with topic, what people want to know. Or if not in this session, maybe when Dr. Srikanth will arrange for another session, we can address those questions. But for now, NMC, it was brought in by Niti Aayog, or the planning committee, before the parliament houses. And after that, the president has given assent in 2019, and the act has been applicable since 2020, that is September 2020. And since then, we've been seeing how its effects are. That is one thing. And MCI has been completely repealed. It has been replaced by NMC, for good or we don't know still. And so the NMC has 33 members as of now, including the chairman. So the chairman, secretary, there are so many directors of the boards. There are 4 boards that have been organized around it, under it. And the 4 boards that are UG, PG, and medical assessment and ratification board, and ethics and medical registration board. And so basically, there was one question that Dr. Srikanth had given to me, that I'll have to address this. So how do we ensure that these members of the board, the chairman, whoever are sitting at the powerful position, actually they are doing their job in a good way? They are they're the right people. Like, for example, there are so many allegations with regard to MCI and how that was working, but how they have ensured, the government has ensured that it does not repeat, which is a very positive mindset with which they have brought in NMC. So they have established search committees, and under the search committee, it is very clear that so I've written down notes, like I old school. To ensure transparency and accountability, they have ensured that these members have to declare their assets. At the time of becoming a member, they have to declare their assets. And even at the time of their, after I guess 4 or 6 years is their tenure, and they don't have an option of getting re-elected to the board again. So during that period, they might have earned the next amount, but at the time of leaving, they have to declare their assets again. So which ensures transparency. And apart from that, account auditing. So accounts are audited at a regular interval. At least that is given under the act that it has to be done regularly. And apart from that, so after to ensure that there is no system where the person who after leaving he or she shouldn't ensure, right, that I will do something good for you. There shouldn't be any quid pro quo of any negative kind there, where I will give something in favor of you and you can give me an appointment in some big medical institution or some educational institution or hospital. So that is why they have ensured after that completion of that tenure for 2 years, that person should not be working anywhere. And during the term also, if that person is found out to have some vested interest, that person should not have the right to decide that particular case, that particular scenario, or adjudicate anything pertaining to that, or make any planning. So all of this has been ensured under the Act, just so that new allegations don't come up even against this NMC. And the next thing is, hello?
We can hear you. You're quite clear. Carry on. We can hear you. Carry on.
So the next thing is, under section 44 of this NMC Act, there is so all the commissions get some amount of grant fund or some money from the central government. So this NMC is established by the central government. So accordingly, they also get some amount as grant. So every year they have to provide for what purpose they have used that fund, and give a clear report. And if needed, the auditors can even dig deeper and find out where exactly that amount has been given or spent. So that is to ensure transparency. And apart from that, the most important question when Dr. Srikanth and I were talking. So Dr. Srikanth mentioned that there are so many activities. We see NMC in news very, very frequently these days, how they've been very active with regard to medical institutions, and how doctors are getting scared that what about the future? Why, if there are not going to be enough doctors for future and all. Now that is something initial, can't comment about it, and let's see. Obviously those institutions are going to make an appeal, and we'll see what happens with regard to that. But in case, in the time being, if the central government for any reason feels that NMC has not been doing a good job, or not been able to, there are more allegations coming in. Of course, they have to be proved in future. But if in case there is a lot of issues that is happening with regard to that, and the complaint goes to NMC, they can actually take over for a period of 6 years. And in case that is also not going to resolve the issue, they can even set a whole new board. So basically, there are a lot of checks and balances which have been provided in this NMC Act itself, to ensure that no person gets complete power, and there's no corruption, possible corruption that should happen under this. And let's see, it's anyway a very new act, and we have been seeing already on the news that they are in action. And mostly what we have heard of is this I guess medical assessment board, wherein they actually see if the medical colleges are functioning according to whatever the standards are, and if they are giving the right education and fees and everything. So they have a say in most of the concepts. So let's see about that. And apart from that, I guess there is one more topic which was a burning issue when this had just then come. I'm not sure if it's still a burning issue, but community healthcare provider, right? Wherein people who are not essentially allopathic doctors and medical professionals get some medical training or allopathic training, and they can go and practice in rural areas. So there was a lot of hue and cry over that. So we've got to see. As of now, though, I don't see any update on it. But going forward, probably there would be something new. Is there something to add, Dr. Srikanth?
No. So that's fantastic. Carry on. Yeah.
So yeah, this is from my side. And apart from that, some of the other queries that Dr. Srikanth had added was checks and balances, which I just addressed with regard to how NMC itself, amongst the committee members, how they have ensured checks and balances from the search committee. So there's a check and balance even on the search committee, who should be the members of it, and how even if any of the board members are not doing the right job or a good job, they can be removed. But of course, by following principles of natural justice, so the other person has to be heard and everything. So after that, so that is one point. And yeah, I guess this is all that I have answered. Please let me know, Dr. Srikanth, if there is anything else that you would want to ask right now.
Fantastic, Ananya. It was amazing. Thank you so much. Just one question. So what will be the same, the checks and balances for, say, district court? So what will be, how a district court is regulated in India?
So that is completely different. It is not something that I would want to touch upon right now, because see, even with regard to doctors, see, I understand you mentioned about your friend's land matter, and also probably you're linking something with that. But when it comes to land matter, yeah, that will become an original suit, and it will go to district court. And if not, if the person has not received the appropriate measures, or their grievances have not been addressed, they can appeal to the High Court, and from High Court then Supreme Court and all that. So that is something again completely different. And then if you say for the doctors, then I would say, so even under this act, even like KMC, if anything goes adverse in KMC, honestly that is something quite rare, right? In KMC at least. So that is also established under this NMC Act right now. So from KMC, it is going to go to National Commission, and then National Commission to higher level, so Supreme Court next. So that is how it works. And then if you say consumer cases, so consumer, that will come under Consumer Protection Act. So there also there are 3 tiers. So first there is District Commission, next there is the State Commission, next there is National Commission.
So since today's topic has been on AI, and as a lawyer, I'm asking you, because we are 2 experts, in the world talking about AI in medicine. So what's your take on AI in judiciary? Can AI come into judiciary at a level lawyer, judge, and dispose of all these 5 crore pendencies in India? I mean, so younger lawyers like you encouraging that, or older people preventing you from doing? What is the present scenario in AI as far as law and judiciary is concerned?
Honestly, at a practical level, I agree. You have spoken a lot about pendency of cases. I understand that's a very big grievance for you and probably a lot of your community people also. But the thing is, see, like how I explained, first district court, then High Court, then Supreme Court. So every single case has its own, it'll run its own course. And that time frame is also required, and there are a lot of cases, and there are a lot of advocates also practicing in the courts, but somehow it does not get over quickly also, because every single person has to be heard, right? So in case there is the most relatable topic for doctors right now would be consumer cases or KMC cases only, wherein the complainant would have made his complaint, and then you would have to defend yourself, right? So now if the judges or the quasi judges, whoever it may be at that point of time, if they end up listening to only 2 sides, and at that point of time they try to finish it, it might be against principle of natural justice, not hearing both the parties properly. So that is the reason so much is required. Like so many times cross examination is the stage where parties actually start opening up to a lot of points. So there are a lot of application and to that we keep making. That is the reason it takes such a long time for one case to eventually run its course, and finally the judgment comes out. And see, I understand a lot of doctors, wherever I go, right, they end up telling, why don't judges work on all days? We as doctors work 24/7 so many times, and we still don't get any rest. So the judges also do it. In fact, my grandfather was a district court judge. He retired 20 years ago, at least 19 years ago. At that point of time also, he had to work really long hours. He had to read and read. Today, just to talk, I had to go through, I just talked so much, but I had to go through that equal number of material. So that is how deep all of these concepts are. And for one judge to actually get to that point, he has to do so much research. The lawyer brings in a lot of research, he produces all the research. Judge has to go back, even though the court timings may end at 5:36. The judge has to go back, do his homework, come back prepared for the next date. So that is what takes a long time. And vacation period essentially is not even vacation. I guess that's for everybody, right? Lately, even if you're in employment, even if you're not in employment, self-employed, you barely have any vacation. Even on vacation, you keep working. The judges also do the same thing. So that is it's not something that these people are the reason of pendency. And with regard to AI, at this stage at least, practically, if I have to tell, we do use AI, but that has only mostly been to assist us with drafting or researching, looking up for case laws. It actually helps us to mix all get the exact match of the cases. So we also have our databases. So the moment we type in the keywords, we get cases similar to that. So that is shortening our span also a little bit, the time period that we are taking. So it has been a good thing for us. And like how Dr. Harun and all also mentioned, that over time AI learns, right? So we also initially, like 1 year ago when we were using Chat GPT, and to now, there's a lot of difference. We get better answers today than what we used to get earlier. But at the end, someone to ratify is required. So advocates do, we have to ratify and finally give our opinions or drafts.
Fantastic. They say that nobody can stop whose time has come. That I think this is a time for AI, and hopefully it will make our life much more simpler and easier. Any questions for Advocate Ananya? Dr. Raghavendra, you got any questions? Anybody any questions? Dr. Mohsin? Okay. So Ananya, thank you so much. You've been fantastic. I think this was Ananya's first talk to 803 delegates, and she has done fantastic, brilliantly. It takes me back to my own days, when I had to do my first presentation in Royal College of Surgeons, more than 2.5 decades ago. It was a joint British-Belgian society, and I was supposed to present in front of all the hand surgery professors whose books I had read and developed as an orthopedic surgeon. Very, very nerve-wracking, but it was okay. And I think Ananya has done extremely well. So I thank you very much for your time, and thanks for all your hard work. We'll sort of connect again. And if I can go back and slide share, before you go off, I'll see if I can just a quick felicitation I can do. I'll just bring up my slides. So 1 second. I think since you didn't have presentation, it's easy for me to present my thing. So 1 second. Yeah, so there we are. So stop share. So I think this will be a sort of online felicitation. Thanks, Ananya, for your time. Thanks for your time, contribution, guidance to the medical community. So we'll catch up later. So thank you very much. Have a great day.
And thank you for the opportunity and actually motivating me to talk today. I have to give you the credit for all of this.
You've been fantastic. You've been much better than professional. So thank you. Thank you so much.
Thank you.
Bye-bye. Bye.
Bye.
Right. So I think, there is a felicitation of the guests here, but, vote of thanks, I take this opportunity to thank the distinguished faculty, Dr. Harun for coming, Ananya for being here, and, Everett for joining and sending me the video, and, Dr. Ashok Shyam from OrthoTV, Dr. Neeraj Bijlani, unbelievable surgeon, very, very meticulous, and not come across somebody who's so meticulous, both digitally and as an orthopedic surgeon. And thank Maharishi as also for his patient time today. I thank all the guests of honors who came, Dr. Pradeep, Vice President of IMA, and Zulfi Kadir, who came and he had another meeting, he had to go away, Dr. Mohsin. Thank all the delegates, both online and offline, for your valuable time. So thank you very much. Till next time, goodbye. So Maharishi, thank you. If you want to stop, you can stop. We'll just carry on with the physical felicitation here in the hotel, and we'll carry on. Okay, thank you very much. Lights again. Harun, please come. Please take a seat here. Dr. Harun, I know you did your PPS from Bangalore, but this is our Mysore way of doing the presentation. Please take a seat here. Please come. Please take our guests of honor.
It's a very traditional way of honoring the doctor.
It's such a pleasure to have you. I'm very happy that you elicited the best OrthoTV response in 6 years. That's, I should congratulate you. It's never crossing 500, so you made it 803. So then it's recorded. What people will watch tomorrow. So Mysore way of felicitating all our guests.
Really smart too.
Fantastic. What is it? Yeah, yeah. Please be seated. You are my very good friend. Please sit down, sir. So he's owner of Aspire Hospital, one of the kindest doctors I have found in my life. So I'm really privileged to honor sir. Just be seated, sir.
For honoring me to this level.
My friend, and you are a doctor. I don't need anything beyond that. You are a great doctor. That's all. Sir.
So much. God bless you. All of us should stand together.
It's okay.
Yeah, I think we'll do that for you.
My professor is coming, so that's the last professor Ramesh.
He's coming now.
He will come at 9:30. Basically, one I kept. So two more.
No. Actually, can I?
No, it's there. It's very open.
I just happened to meet Srikanth, Dr. Srikanth once, and I said he must be straight. The first time that he met in the hospital. Yes.
Patients are very, very happy. AI can do this other, but AI can't do this. That's what I'm saying.
I think if you can tell that message, can you record it?
Dr. Mohsin is one of the kindest doctors I've seen. We just did an expert almost symposium on audition today. Both in orthopedics and Harun from UK. We talked about radiology. I think AI can replace many doctors. It's true, but AI can't be replaced doctors like Mohsin because he's sympathetic.
That's the best compliment that I could receive.
Most GPs are okay. So
At the end of the day, I think yesterday had a patient. Sir, you should do this. Sir, if sir is free sometime, please have lunch together for a half day.
Okay, so first of the meetings, he's a very, very busy person. So tomorrow morning, taking a 6:30 or like to Jaipur.
But anytime when you're
Hello, Dr. Srikanth, sir.
Honestly, thank you so much. You can close it. Yeah, I think you're not there. So you can close this and please.
No, sir, I am here.
Yeah. So I asked you to close it around 10 minutes ago. You can close it and you can
Okay,
edit
sir.
the last part, last 15-20 minutes. Okay. Thank you so much for your help. Okay. Say thanks to Ashok and Neeraj. And I'm going to speak to him from Jaipur tomorrow because I want to speak to Dr. Ashok today, but I couldn't. I will catch up with him tomorrow. Dr. Harun wanted to speak to him. So maybe post lunch tomorrow, we'll catch up with Dr. Neeraj and Dr. Ashok. Okay.
Okay, sir.
Okay.
Sir.
Thank you so much. Thanks for your time. Okay.
Okay.
Have a good day.